to a decrease in blood pressure that will benefit from fluid could be to increase the level of the vasopressor, meaning that we're not treating the patient most appropriately because we'll rely on something that is easier to use. Now, regarding your specific question about that table, I thought it was interesting that the groups of patients in that analysis, there are about 18,000 patients, were grouped based on whether or not they remain hypotensive after giving fluids, and by different levels of lactate in the blood. So if you compare the groups for those characteristics and look at mortality that was reported in that table, it just happened that the patient who were on a vasopressor had higher mortality. Now, I'm not saying that that was the reason for that. Maybe those patients were sicker, that was not captured in the way the data was analyzed, but I think we should look into that. And the other things we can discuss, the underlying pathophysiology. What does it mean to be vasodilated? Does it mean, that means that some organs are getting more flow for a given level of pressure. So when we give a vasopressor agent, we might be compromising certain organs that we're not aware of. I have experience of several cases in which I have focused on the perfusion, mental alertness, a good heart rate, and urine output, and allow the blood pressure to drop and not jump into a vasopressor agent, and patients have pulled through without much difficulties. So I just wanted to say that we need to revisit the concept. One more brief comment. If you look at the indication, at the data behind that, I mean, the guidelines admit that it's low quality. It's a level C. And if you start looking at the studies behind the recommendation, there's very little evidence that is solid to recommend that maintaining a blood pressure, a mean arterial more than 65, really improves outcome. And then we have the studies showing that different levels of blood pressure target do not alter the outcome. So there doesn't seem to be a dose response. That is my line of argument.
Thank you very much. Any other questions, comments? Nobody? Okay. Now we proceed with Ms. Eliana Ipses, who is a cardiovascular perfusionist, to briefly talk about the experience of ECMO in the Middle East.
Ipsis from McKay Middle East. Now we're called Getinga Group. Most of the only product we use is the Cardio Help when it comes to ECMO. So I want to talk a little bit about who we are, where we come from, and what we have seen in the Middle East thus far. So McKay is in Rastatt, Germany. This is where our main headquarters is. We are 3 teams into one. So the Getinga Group is with Arjo Huntley, who does our our beds and DVTs. Getinga Group does the infection control, and McKay Middle East does the cardiovascular equipment. So to cover the Cardio Help itself, the Cardio Help can be used anywhere. It can be used in the ICU, the cath lab, the operating room, and as you saw with Dr. Nick, you can see it, we can be transporting patients with it. It has 5 different therapies on it. We have venous ECMO, veno-arterial ECMO. We can do open heart surgery with it, and coming soon we will have the pump assist lung protection. This is for CO2 removal. This is going to be coming hopefully in the very near future. We also have a ventricular assist device, a short term. All of these, except for the MAX system, which is the open heart surgery system, can be used for 30 days continuously. In the Middle East, we have covered almost every single country. We are covering 16 countries. This is including Pakistan and Afghanistan. We currently just had the first ECMO case successful weaning off in Pakistan 3 weeks ago. So here, our commitment in getting a group is to do trainings. We do on-site trainings, we do international trainings, and we also will stay with you until the patient comes weaned off. So our reference centers, we have multiple reference centers throughout Europe. We have on-site trainings and the ECLS guideline. The ECLS guideline will cover indications, contraindications, how to pick out the different types of cannulas, what are you looking for in terms of labs. Our first reference center is in Milan, Italy. This is in San Rafael Hospital. We usually send intensivists, cardiologists, cardiothoracic surgeons, and perfusionists to see live cases. It's a very, very busy center, and they use our ECMO quite a lot there. Our second center is San Antonios Hospital in the Netherlands. They do 980 cases of open heart a year, and this is including ECMO as well. On-site trainings, there's 3 of us. I am the perfusionist in the group, and as you can see, I have been to Kuwait, so you do have our cardio help here. So there is currently 4 cardio helps throughout Kuwait, and they're running quite often. So these are things that we need to start looking at. How do we increase our survival rate on ECMO? What do we need? Dr. Nick talked about having a team. This is the most important thing. The ECLS guideline shows us the priming and setting up, cannulation sizes, indications, contraindications. These are extremely important things to have with you at all times. And finally, we also provide continuous studies to the people who are running ECMO. That way we're continuously learning and educating throughout the Middle East. Clinical support. Throughout every case that we start with the ECMO, we are there for the first case. We try to be there. When we are looking at the cases, one of our biggest breakouts that we had in the Middle East is the coronavirus in 2014. This was a huge problem in Saudi Arabia, and it did spread here to Kuwait. The first case was done in Dabus Hospital, and it was a corona patient who was on for 18 days. He did survive. He was weaned off of ECMO. It did make it also into the political news. So this is very important that we start seeing and helping the patients of Kuwait as well. The first case in Egypt, Cairo, Egypt, was an H1N1 patient. He is a doctor, a cardiologist, who got H1N1 from a patient. When I went down, it was complete white lungs. This was day 11 that you see the white lungs here. On day 22, he was weaned off, and he was discharged, and he did go home. He was a very young doctor, so we wish him all the best. The most recent case I did was in South Africa. This is a very interesting case report. The patient was 48 kilos and 176 centimeters. So you can only imagine how skinny this kid was. 25 years old with cardiomyopathy. What we want to look at here is the lactic acid was at 11 and his ejection fracture was at 15%. The first thing they did, they put an intra-aortic balloon pump into the patient. Then they saw that this was a VA patient. So they went ahead and put him on veno-arterial ECMO. This is the most common way to cannulate. This is the most common way to cannulate, and he was on full support. What he had was his aortic valve was completely shut. There was no way of his aortic valve to open, so he started getting hypertrophy inside the left ventricle. which led to a positive feedback, which caused pulmonary congestion. So that caused a feedback again and destroyed the right ventricle as well. So what we did is that we put in an LVAD. The patient was on ECMO while we were putting in the LVAD. We weaned off of ECMO for exactly 50 minutes as the LVAD went in, kept recirculating the ECMO. So as you can see here, we kept recirculating. This was when the ECMO was off on standby. The patient has been weaned off and, he was put on right heart support during the case. He was cannulated in the pulmonary artery, and we kept in the venous femoral cannula. So he was weaned off on December 5th, and now he's slowly being weaned off the ventilators. He did survive, and every time this kid woke up, how bad his muscle capacity was in his body, whenever he got up from sedation, his SVO2 levels just plummeted. We went from 78% down to 51% on SVO2. He had no muscle mass in his body. He was a very sick kid.
Summary, please.
So it was very good to be able to help him. I skip a little further. With getting a group, next year we will be having the SWAC ELSO. This will be in Doha, and also Euro ELSO in the Netherlands. So, in conclusion, the CardioHelp has saved many lives throughout the Middle East. This is an excellent product for transporting patients, being able to have patients roll around in the hospital and be awake and walking around. And finally, we provide the guideline as well. Thank you very much.
Thank you so kindly. That was great. Thank you. Let us get on. We will break now for coffee, prayers break, and then assemble again at 5:30 here so that we can continue with the SIM war. Thank you very much.
Second simulation session for this conference. Today it's going to be the second scenario, and it's going to be the competition between Mubarak Hospital and Amiri Hospital. So today we have the Mubarak team here in front of the camera. Okay, so we're going to start. Tarazan. Okay, so this is your scenario. You have a 45-year-old male patient who's scheduled for an elective laparoscopic cholecystectomy. You are in theater with the patient. You have finished inducing the patient with propofol, atracarium, and fentanyl. The patient is now intubated. He was grade 1 intubation, so no problem with that. He's connected to the ventilator. Okay. He's connected to the ventilator and is ready for surgery. You have started giving the patient 1.5 grams of cefuroxime, which is there. So you can start giving that now, okay? And this is part of the surgical site infection prophylaxis. The surgery starts as well at the same time. So on you go, okay? So you can go at the bottom. You're the surgeon. Okay. So that's your patient.
Okay, that's okay. Okay.
Will you give it, doctor?
She will give.
Yes, doctor.
Did you check his allergy? يعني allergen بس septic check test and this is a septic check test. Did you check his allergy?
Let me check.
This is
كم نقول في داون here? 22. Not in the
Shall I carry on with the surgery?
Okay, stop please, stop injection. Have the patient is dehydrating now and the BPO pressure is rising.
I've given it already.
You given already?
Yes, doctor.
Don't give any further please.
Yes, sure.
Okay.
Saturation is doping, 100% oxygen.
from here. Good.
We have chest wheezes. I think he has anaphylaxis from the antibiotic. I need a help, please.
Can you come, doctor, please?
Can you come, doctor?
Yes.
We need help,
Hello?
please, here.
Hello?
Patient is hypoxic. We increase. Okay. Can we give now, please, epinephrine?
Let's check the airway quality.
Okay.
Let's check
We
air
have
quality.
hypoxia.
Epinephrine,
Yes.
how much, doctor?
50 microgram,
Yalla.
please.
Yes, doctor.
50 microgram of epinephrine. I need
Hydrocortisone, okay.
100
Yes,
milligram.
doctor.
100 milligram.
Yeah.
Epinephrine given.
Stethoscope, please.
Can I have the hydrochloric?
Stethoscope, please.
Good.
The tube is in. We have to double check the tube also.
Make a FI 200%, please.
And equal into auscultation.
With FI 200%.
Excuse me. Make it. Now it's manual. It's manual. No. Okay.
Check, yalla.
Hydrocortisone given, doctor.
Still bilateral wheezy chest.
Can we have salbutamol nebulization, please?
Okay. Okay,
Yes,
doctor.
we'll put that,
Coming.
doctor.
Hydrocortisone was given.
Yes, doctor.
Yes, giving.
Okay. I think we have to give H1 H2 blocker.
Cloftamine, please.
Blood
Cloftamine.
given. Yes, doctor.
Also IV fluid, please. I need
Yes,
to transfuse 1 liter warm
10
fluid.
milligrams. Yes.
Cloftamine.
Yes.
Can we transfuse 1 liter warm fluid, normal saline? Fast, please.
Wow. I'll prepare. I'll run the saline now, doctor. Morphine remain given.
Then breathing. We have a chest wheezes, muscles.
Morphine remain given.
Now, epinephrine
Morphine
again,
remain
please.
given.
Another 50 microgram.
Epinephrine.
Okay, Lali. 1 second. 1 second. Epinephrine ready.
Still desaturating.
Okay.
Okay, I think we have also to deflate the stomach, the abdomen, because of the also with acid infiltration. So deflate the abdomen, please.
Still desaturating.
Separating fast.
Epinephrine given, doctor.
Can we get an ambo bag, please, and oxygen with
Yes,
ambo
doctor.
bag? Maybe our
Yeah, can we ventilate with ambo bag?
Yes.
Yes. Give me an ambo bag with oxygen. So
Okay.
we should think of the displacement of the tube. We have equilibrium.
Okay.
Can we do suction of the 82, please?
Suction,
please.
sure.
Suction, please. Can you also ask, do we have an equilibrium?
It's okay. It's okay, Sister Lali. Okay.
Still wheezy chest bilateral and still desaturating.
Okay,
Do
boss.
suction.
Can you check
Okay.
blood pressure again, please?
Yes.
Okay. Okay.
Okay, thank you. Again, we have 200% oxygen. We have partial oxygen here.
Okay. I'll help you.
Okay.
Can you establish the chest? Now the big airway is 19.
There's the case there on this side. I think I got a pneumothorax.
Yeah.
So we have to attach an ICD. Can I get an ICD,
Oh,
please?
yeah,
On
sure.
the left side here. Fast. I need an underwater seal, please. Let's put the underwater seal.
Getting it.
Now let's auscultate it again after fixing the
Okay.
ICD, how the air enters.
Now saturation is 0. Yeah. Let's cut it again.
Blood pressure not measuring.
Not blood pressure not measuring.
No.
طب can you check the pulse now?
Okay.
I think now no pulse is a
Start immediate CPR.
CPR. Yeah. Okay.
1, 2, 3, 4, 5, 6, 7, 8.
Give please give 1 milligram epinephrine
Yes, doctor.
Sorry,
IV
Lali, sorry.
with bush.
Okay, okay, I have epinephrine. Lali. It's okay.
So are we missing something?
Given.
Think about the T's and the H's.
Hypoxia is
Given.
the most
Timer.
likely cause of arrest.
Because saturation is 0 now.
Okay.
Arrest while intubating the patient.
Yeah.
Equal entry.
Given.
Given the treatment.
Nothing given?
Given
Yes. Given.
Let's analyze them. Can we give fluids, please? Get warm saline, 1 liter.
So what you are considering is this cause of cardiac arrest,
This is also hypoxic cardiac arrest.
hypoxic cardiac arrest, because